Thank you, Mr. Chairman. Let me start by showing you the sad truth of pancreatic cancer and its outcome in Europe. In 2012, in 27 EU countries, we had 78,654 patients with pancreatic cancer. And about 90% of these patients are deemed locally non-resectable, have advanced metastatic disease, and only about 10% get some form of treatment with a curative intent. Of these people that get this treatment, again 90% will die because of a non-radical resection or recurrent disease, and only maybe 10% survive. And in fact, these are the actual data from the database in 2012, which shows you that overall less than 1% of patients with pancreatic cancer survives. So that's the sad truth of pancreatic cancer at this point in time. So the question then comes to mind, how to improve survival? First of all, I showed you that only 10% of the patients get some form of treatment with a curative intent. That's much too low. So first of all, we have to improve the access of patients to the appropriate healthcare resources. And secondly, and we heard an excellent talk just now, we have to develop, of course, more effective treatments for these patients. But there's a long way to go there. There is a possibility of primary prevention. We know risk factors, we know preventive factors, we know true risk factors, and we could try to modify them. And of course, and that's my talk, we could think about secondary prevention and target people, persons who we know at high risk, to do some form of screening. Now, with regard to risk factors, we know that, for example, smoking is a very important risk factor, odds ratio of about 2 to 3, and it's estimated that about 25% of all pancreatic cancer in Europe are caused by smoking. If you think about this, that would mean if we would be able to decrease the percentage of smokers by 5%, we would do more than all treatments that we as doctors give to patients with pancreatic cancer. But of course, we know that's very difficult to achieve. Primary prevention, changing people's habits, is a very difficult thing to get into people's mind. You see that the effect of smoking lasts quite long. You have to stop smoking, and then for many, many years you're still at increased risk, and that only subsides and gets back to normal after 15 to 20 years. There are other risk factors. Diabetes, always the question of whether it's the chicken or the egg, a high body weight, alcohol use, and chronic pancreatitis, where we know that there's a 4% chance of getting pancreatic cancer in about 20 years of time. We also know about genetic risk factors, and approximately 10%, maybe a little bit higher, 10% of pancreatic cancers, genetic factors play an important role, and this could be a target for then maybe secondary prevention. We know about cancer susceptibility syndromes and genes, and very importantly, we distinguish between two groups. First of all, a group of people where clearly there's an autosomal dominant inheritance pattern of pancreatic cancer, but we do not know the gene in those families. The risk is substantial in people, in persons that have more than 3 family members affected. The relative estimate and the risk factor goes up more than 17 up to 33 times. So that's substantial. The problem, if you would screen those families, you have to screen all of them, and you don't know whether that person is being affected. So effectively, you screen half of them for no reason, because they do not have the high risk. There's also a group of syndromes where we know the mutation, and we also know that besides, in many cases, other occurrences of malignancies, also the chance for pancreatic cancer is increased. We know the BRCA1 and 2, the mismatch repair genes, in particular the hereditary pancreatitis with a very high risk, up to 30-40% lifetime risk, and if people smoke, it's 70% lifetime risk. Poor families, quite high risk, up to 32% lifetime, and then the familial melanoma, the P60 mutation. These are conditions where we can screen families and where we can identify affected persons and do targeted screening. Now, the ultimate goal would be, of course, to prevent early death. And you might want to detect an early asymptomatic cancer, because we know that's better curable than a symptomatic cancer. But still, a type 1A cancer, so a cancer confined to the pancreas, smaller than 2 centimeters, with no lymph node involvement, with no vessel involvement, the 5-year survival rate is only about 20 to 25%. So what you would like to do is to detect precursor lesions before they have progressed to malignancy, because if you resect the precursor lesion, the patient can never die from a distant metastasis because it was not cancer. And do we know benign precursor lesions? Can we target certain lesions? Yes, we do know these lesions, and we know them for quite a long time. We know lesions like pancreatic intraepithelial neoplasia, which by themselves are microscopic lesions, so they probably would never be visible on imaging investigations. But when multiple of these lesions are in the same location, they cause some kind of atrophic effect, and you could see early signs of chronic pancreatitis, which we can detect, for example, with endosonography. We also know the IPMN, intrapancreatic mucinous neoplasia, branch type, main type, we know them very well, and in fact with the increased use of cross-sectional imaging, we see more and more of these persons having IPMN, also outside families with an increased risk. And we have to deal with that, and we have to deal with the potential risk of developing pancreatic cancer, but at least it's a lesion that we can target in these families for screening. And there is a small group of people with mucinous cystadenoma that can also develop into a malignancy and could also be a target lesion for screening. Now we also know, in fact, for quite a long time now, that there is a stepwise progression of these lesions from a non-malignant lesion finally into a malignant lesion. And in fact, this resembles what the vocal sign theory has shown for colonic cancer, where you have, of course, first a normal duct, and then you get low-grade dysplasia, penin type 1A and B, that might evolve into moderate dysplasia, penin type 2, into 3, high-grade dysplasia, and finally to adenocarcinoma. And you also see that there are all kinds of genetic aberrations ongoing in that sequence of time that also might be targets for identifying patients at risk, and maybe also to identify at what specific location they are, what specific penin type of lesion they have, because it's much different if you have a penin type 1A lesion or a penin type 3 lesion, for example. There's also in the IPMN lesions, we know there is a correlation between gene mutation and dysplasia grade. And some of these mutations, you can see that from adenoma to borderline lesions to carcinoma in situ to invasive carcinoma, there's a steady increase in the prevalence of the mutation. For example, for the telomerase lesion, telomerase mutation, for the sonic hedgehog mutation, for example, for the P16 mutation, which I showed you the family history just a few slides ago, and for some P53, DPC4, and BRG1. So these could be targets not only to identify patients at risk, but also to screen for whether a certain lesion already has progressed to a lesion that is at high risk of developing into pancreatic cancer, borderline lesion, or carcinoma in situ. Now, if we know these precursor lesions, then the question is, what is the interval for progression to invasive cancer and carcinoma? And do we know anything about this? Yes, we do. The Genetic Evolution of Pancreatic Cancer, this is a very interesting manuscript, which I urge you to read, from Yashida in Nature in 2010. And it shows us that the development from a normal duct epithelial cell into a metastasized pancreatic cancer takes quite a few years. To go from a normal ductile initiated tumor cell to a founder cell of parental clone, it takes on average 11.7 years. Then from that founder cell parental clone to develop into subclones with metastatic capacity, it takes an average of 6.8 years. And then to finally develop metastasis into lung, liver, or bone marrow, for example, it takes an average of 2.7 years. So there is at least a large window of opportunity to detect early lesions that might predict a person to develop pancreatic cancer. Now, of course, the holy grail will be some kind of a biomarker in blood. People are searching for that. not so much evidence yet. CA19.9, circulating pancreas epithelial cells, saliva, some microRNA have been tested, some preliminary evidence that this might be a way to go. Stool testing, not only for DNA, but also people looking in the fecal microbiome, and pancreatic juice to look at methylated genes or mucins could be an interesting target. And particularly this latter target, pancreatic juice, is interesting because if, for example, we screen people with EUS, with endosonography, we are in the duodenum and we can collect pancreatic juice. And this has been shown by the Baltimore group, where they collected pancreatic juice from the dual lumen after administering secretin, just by suctioning the juice that was extruded from the papilla. And they looked at GNAS mutations, and what they were able to show that in case of persons with IPMN, they saw the GNAS mutations in 64.1% patients and in none of the patients with disease control. So it doesn't tell us anything about the dysplasia grade, but this tells us something about the feasibility and also about the presence of these lesions of IPMN. Interestingly, they had 97 subjects who had serial pancreatic juice collections, and in the persons in whom they detected GNAS without seeing morphological abnormalities pointing towards a IPMN, later on during the follow-up, these people developed these IPMN lesions. And this points towards the possibility of pancreatic juice analysis to very early on detect and show us the development of IPMNs. And of course, we are looking for mutations that not only show us the presence of IPMN, but also, for example, dysplasia grade of IPMN. So far, most of the data has been searched for with imaging techniques, MRI, which of course is a non-invasive technique. It has a good sensitivity and specificity for diagnosing pancreatic cancer in patients that are symptomatic, no radiation exposure. And of course, we have EUS, which is an invasive technique, has also very good sensitivity and specificity. It's in particular sensitive for small lesions, and despite the fact that we have to, of course, intubate a patient, there's a low risk for adverse events, but importantly, it's also operator dependent, which is probably less true for MRI. Now, many studies have been published. It's very difficult to give an overview of these studies because the number of patients differ, the risk groups assessed differ, the test people use differ, the interval of tests differ, the way they define diagnostic yields differ. But at least the overall picture of these studies is that it's feasible and that there is an increased prevalence of, in particular, IPMN lesions, which in certain risk groups can differ between 15 and 45%. So that differs from people that get a EUS investigation that do not have a familial background of pancreatic cancer. In 2011, we had a CAPS meeting in Baltimore, USA, and together with people working in the field, we tried to reach a consensus what we would consider lesions that, if we would remove them surgically, were a success, because that's very important if you talk about future studies. And we decided that if a patient of a person would be operated because of some features found on imaging, and it turned out to be an invasive cancer, T1, N0, M0, IPMN high-grade dysplasia, MCN high-grade dysplasia, unifocal or multifocal panin lesion, or a neuroendocrine tumor greater than 0.5 centimeter, that would be considered a success. And we hope that all the future studies will adhere to these criteria to better be able to combine study results and to draw final conclusions. We're now doing a prospective study in the Netherlands with the main outcome parameter to look for the percentage of patients in whom a relevant pancreatic lesion is detected. Of course, we look at many other things, secondary outcome parameters. And importantly, in these persons, we also acquire yearly collection of bodily specimens like blood and fecal samples for future biomarker studies, because it will be very interesting, of course, in this particular cohort of persons where you know that at least 10% of these persons will develop finally a lesion of interest, how in time certain mutations behave. What are candidates for pancreatic cancer surveillance? We have defined this as individuals with at least 3 relatives of any degree of pancreatic cancer, individuals with at least 2 first-degree relatives of pancreatic cancer, any member of a Purge-Jaeger syndrome family. And you see here some of the other mutations, BRCA1, BRCA2, PALB3 or P60 mutations with at least one first-degree relative, and individuals with Lynch syndrome with also at least one first-degree relative. And we have defined this criteria to restrict ourselves to persons that have at least a 10-fold increased risk of developing pancreatic cancer. Now, the surveillance policy is to do yearly EUS and MRI in this study. When no focal lesion or as a stationary cyst without any worsening feature, we do a follow-up after 12 months. If there is a focal lesion, it depends whether it's a newly detected site-bench IPMN of less than 3 centimeters, then there's a follow-up for 6 months, and if nothing changes, the patient goes back to 12 months interval. And if there is a mass lesion or any worrisome feature like a intramural nodule or a thickened asymptomatic cyst wall, there's a national expert panel and the patient is discussed, and then we do either interval EUS after 3 months or we do a resection. We start at an age of 50 or 10 years earlier than the youngest relative with pancreatic cancer detected in that family. Here you can see a case example. I'm not sure if I can show you, if I have a pointer. The video doesn't run? I don't think the video is running, which is a shame. I would like to show you one of the first patients that we identified. It was a young woman of about 50 years of age, where we detected an 8-millimeter pancreatic cancer lesion that was finally resected. You can see it over here now. I don't have a pointer, but below you see this black area, that is the ultrasound probe, and below you see the pancreas, and you see 2 other black markings, which are the vessels, the splenic artery and the splenic vein. And there you see a small round lesion of about 8 millimeters, which in fact is a pancreatic small cancer of an asymptomatic person. This woman was operated upon, and it was a R0 resection, and we were relatively happy, and she was relatively happy because we had detected this early, but unfortunately, a year later, she developed liver metastasis, and she died of an 8-millimeter pancreatic cancer, giving more emphasis to the fact that we should aim for detecting and finding advanced precursor lesions rather than pancreatic cancer. We have now 230 persons being screened and participating. Now it becomes a very important time period because we have a median age in our cohort of 52 years of age. We know that the average age at which these persons develop pancreatic cancer is 65, and we have this 10 to 15 years lead time. So it's very interesting what will happen in this cohort with regard to the development of lesions. What we have found in 106 individuals who had at least one follow-up examination after the first index examination is that one of these persons developed a premalignant lesion that we were able to resect and the patient is still alive. 10 of these persons had a lesion already detected at the first investigation that progressed and is still being followed. And 4 of these persons did not have any lesion at the index investigation, but developed new lesions during follow-up. So this is an interesting cohort to follow what will happen. Well, is this now feasible from a psychological point of view? Yes, it is. We did a questionnaire there amongst 69 of these patients. Interestingly, by the way, EUS was not perceived as more burdensome than MRI. So this invasive investigation using a scope is not perceived as more burdensome. People worry about developing cancer, but this was not related to surveillance outcomes. Anxiety and depression levels were comparable to the general population norms. And the majority of patients told us that they thought that the advantages of participation outweighed the disadvantages of the investigations. So to come to a conclusion and a summary, Mr. Chairman, we are only at the beginning of exploring the possibilities and prospects of pancreatic cancer surveillance. I think EUS and MR are promising techniques for surveillance. They are able to detect some precursor lesions, but we have to find out whether we can detect them in a timely fashion before they have evolved into pancreatic cancer. This is very important. We need to learn much, much more about the natural history of these pre-invasive lesions. And this is probably the most important remark of my whole talk. And I want to emphasize this, because by no means it is proven yet that we're doing anything good by these surveillance programs for these persons at high risk. And for that reason, I think the only sensible thing to do is to continue surveillance of well-defined high-risk populations, but within collaborative prospective research protocol, including the collection of tissue materials like blood samples. Thank you very much.